Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 368 of our pharmacotherapy series, which majors in fluid and electrolyte disorders. The first case reads, JFA, a 31-year-old man, is admitted to the inpatient medicine service for methanol intoxication. Routine laboratory analysis reveals the following: sodium levels of 145 milliequivalents per liter, potassium levels of 3.4 milliequivalents per liter, a blood urea nitrogen of 10 mg per deciliter, a creatinine of 1.1 mg per deciliter, and glucose levels of 90 mg per deciliter. The blood methanol concentration was 108 mg per deciliter, and the measured plasma osmolality was 333 milliosmoles per kilogram. So my question to you is, what is JFA's calculated osmolality? Are other unidentified osmoles present? JFA's total calculated osmolality is POSM is equal to 2 times the sodium concentration in millimoles per liter, plus the glucose concentration in milligram per deciliter, all divided by 18 plus BUN, in milligram per deciliter, divided by 2.8. POSM is equal to 2 multiplied by 145 milliequivalents per liter, plus 90 mg per deciliter divided by 18 plus 10 mg per deciliter divided by 2.8, which is equal to 290 plus 5 plus 3.6, which is equal to 299 milliosmoles per kilogram. Osmolal gap is equal to 333 milliosmoles per kilogram minus 299 milliosmoles per kilogram, which is equal to 34 milliosmoles per kilogram. In JFA, the entire osmolal gap can be accounted for by the presence of the methanol, because 108 mg per deciliter of methanol will provide 108 divided by 3.2, which is equal to 33.7 milliosmoles per kilogram. It is unlikely, therefore, that other unmeasured osmoles are present, e.g., ethylene glycol, isopropanol, and ethanol. The laboratory determination of osmolality measures the total number of osmotically active particles but not their permeability across the cell membrane. Methanol increases plasma osmolality but not tonicity because the cell membrane is permeable to methanol. Therefore, no net water shift occurs between the intracellular and extracellular compartments. Conversely, mannitol, which is confined to the extracellular space, contributes to both plasma osmolality and tonicity. TAB, a 17-year-old girl, presented to the emergency department with complaints of anorexia, nausea, vomiting, and generalized weakness for the past 3 days. She denied other medical problems and had not used any medications. On examination, her supine blood pressure was 105 systolic 70 diastolic, with a pulse of 80 beats per minute. Her standing blood pressure was 85 systolic 60 diastolic, with a pulse of 100 beats per minute, and she complained of feeling dizzy when she stood up. Her mucous membranes were dry, but her skin turgor was normal. The jugular vein was flat, and peripheral or sacral edema was not present. Laboratory blood tests showed the following: serum sodium levels of 134 milliequivalents per liter. Potassium levels of 3.5 milliequivalents per liter. Chloride levels of 95 milliequivalents per liter. Total bicarbonate content of 35 milliequivalents per liter. A BUN of 18 mg per deciliter. A creatinine of 0.8 mg per deciliter. Glucose levels of 70 mg per deciliter. Random urinary sodium was 40 milliequivalents per liter, potassium was 40 milliequivalents per liter, and chloride was less than 15 milliequivalents per liter. The hemoglobin was 14 grams per deciliter, and white cell and platelet counts were normal. Based on the clinical and laboratory data in TAB, what is the most probable explanation for her presentation? The signs and symptoms in TAB are consistent with volume depletion. The loss of gastric fluid owing to vomiting and decreased oral intake secondary to anorexia led to moderate to severe volume depletion. She exhibits orthostatic changes in both her blood pressure, a drop in systolic blood pressure of 20 mm of mercury, and pulse, an increase of 20 beats per minute. The dry mucous membranes, the flat jugular vein, and the absence of edema support volume depletion as well, and dizziness on standing indicates extracellular volume depletion. Her hypochloremic metabolic alkalosis was probably initiated by loss of acidic gastric contents through vomiting. Her volume depletion increased renal bicarbonate reabsorption, perpetuating the metabolic alkalosis. The decreased renal perfusion brought about by volume depletion enhanced proximal tubular reabsorption of urea, resulting in an increased BUN to creatinine ratio, that is prerenal azotemia. When renal perfusion is decreased and the renin-angiotensin-aldosterone system is activated, the proximal reabsorption of sodium and chloride is increased. TAB's urinary sodium is, therefore, less than 10 milliequivalents per liter. Excretion of the poorly permeable bicarbonate ions, however, results in obligatory urinary sodium loss to maintain luminal electroneutrality. TAB's urinary sodium was therefore elevated, that is 40 milliequivalents per liter. In this situation, the urinary chloride remained low, and this is a better index of volume status. Both urinary sodium and chloride are elevated. However, in patients using diuretics, in those undergoing osmotic diuresis, and in those with underlying renal disease or hypoaldosteronism, even in the face of volume depletion. Physical examination should therefore be conducted as part of the volume status assessment. TAB's volume depletion increased the concentration of red blood cells, which could explain her slightly elevated hemoglobin concentration of 14 grams per deciliter. The next question reads, How should TAB's volume depletion be managed? The etiology of TAB's vomiting should be sought and the cause removed. Because the patient is neither hypernatremic nor hypernatremic, normal saline should be administered intravenously to replenish the extracellular volume and improve tissue perfusion. If the patient is hypernatremic, that is having a greater deficit of water than solute, half isotonic saline or dextrose solution, which contains more free water, should be administered. In contrast, hypernatremic hypovolemic patients have a greater deficit of solute than water. Isotonic or hypertonic saline should then be given. The amount of volume deficit is often difficult to ascertain. Because TAB was severely orthostatic, 1 or 2 liters of fluid can be given over the course of 2 to 4 hours. The subsequent rate of infusion will depend on TAB's response and the prevailing symptoms. The clinician should monitor her body weight, skin turgor, supine and upright blood pressure, jugular venous pressure, urine output, and urine chloride concentration to assess the adequacy of volume repletion. Because the treatment goal is to achieve a positive fluid balance, the infusion rate should be 50 or 100 milliliters per hour in excess of the sum of urine output, insensible losses, and other losses, such as emesis and diarrhea. The next case reads, LJO, a 45-year-old man, presented to the clinic with complaints of swollen legs and puffy eyelids. He also noticed that his urine had been foamy recently. On examination, his BP was 180 systolic, 100 diastolic, and his pulse was 80 beats per minute. Bilateral periorbital edema and 2+ bilateral pitting edema up to the thigh were noted. On auscultation, his heart was normal and his lungs had bilateral crackles. His jugular venous pressure was elevated at 10 centimeters of water. Laboratory tests revealed the following: serum sodium levels of 132 milliequivalents per liter. Potassium levels of 3.8 milliequivalents per liter. Chloride levels of 100 milliequivalents per liter. Bicarbonate of 26 milliequivalents per liter. A BUN of 40 mg per deciliter. Creatinine of 2.5 mg per deciliter. Glucose levels of 120 mg per deciliter. Albumin of 2 grams per deciliter. Serum cholesterol of 280 mg per deciliter. Triglycerides of 300 mg per deciliter. The serum transaminases, alkaline phosphatase, and bilirubin were within normal limits. Urinalysis showed the following: specific gravity of 1.015, a pH of 7.0, protein greater than 300 mg per deciliter, 24-hour urinary protein excretion of 6 grams, creatinine clearance of 40 milliliters per minute. Urinalysis also showed oval fat bodies and fatty casts. LJO was taking no medications and he denied illicit drug use. Hepatitis B serology and human immunodeficiency virus antibody were negative. The impression was anasarca, total body edema, secondary to nephrotic syndrome. What is nephrotic syndrome? What could be the cause of LJO's sodium excess state? Nephrotic syndrome is characterized by hypoalbuminemia, urine protein excretion greater than 3.5 grams per day, hyperlipidemia, lipiduria, and edema. The heavy proteinuria is a result of damage to the selective barrier of the glomerulus. The causes of nephrotic syndrome are multiple and diverse. The causes can be idiopathic, primary glomerular disease, or secondary to chronic systemic diseases, e.g., diabetes mellitus, amyloidosis, sickle cell anemia, lupus, cancer, e.g., multiple myeloma, Hodgkin disease, infections, e.g., HIV, hepatitis B, syphilis, malaria, intravenous drug abuse, and medications, e.g., gold, penicillamine, captopril, nonsteroidal anti-inflammatory drugs abbreviated as NSAIDs. A heavy urinary protein loss results in various extrarenal complications. Hypoalbuminemia reduces plasma oncotic pressure and contributes to the increased hepatic synthesis of both albumin and lipoproteins. This, coupled with the decreased catabolism of lipoproteins, resulted in LJO's hyperlipidemia. Urinary loss of inhibitors of coagulation predispose these patients to thromboembolism. Specific therapy of nephrotic syndrome ranges from simple removal of the offending medication and treatment of the underlying comorbidities to the use of immunosuppressive agents in specific glomerular diseases. LJO's anasarca results from changes in both capillary hemodynamics and renal sodium and water retention. The hypoalbuminemia, 2 grams per deciliter, and proteinuria, that is greater than 300 mg per deciliter, produce an imbalance in the Starling forces across the capillary wall, namely the hydrostatic and oncotic pressures in the capillary and interstitial compartments. The reduced capillary oncotic pressure favors movement of fluid from the vascular space into the interstitium. This leads to contraction of the effective arterial blood volume, which in turn activates humoral, neural, and hemodynamic mechanisms that signal the kidney to retain sodium and water. This underfill hypothesis has been challenged by data, suggesting that hypoalbuminemia plays a minor role in nephrotic edema and the observation that patients with nephrotic syndrome can have increased, normal, or decreased plasma volumes. A defect in the intrarenal sodium handling mechanism that causes inappropriate sodium retention also contributes to nephrotic edema. According to this overflow hypothesis, proteinuric renal disease leads to increased sodium reabsorption in the distal nephron. The mechanism is not well defined but may be related to cellular resistance to atrial natriuretic peptide. Thus, a sodium excess state occurs and edema results. It is likely that the interaction between the underfill and overflow mechanisms results in the production of nephrotic edema. Patients with severe hypoalbuminemia, i.e., serum albumin level less than 1.5 grams per deciliter, who have a severe reduction in plasma oncotic pressure, are most likely to exhibit evidence of the underfill phenomenon. The next question reads, how should LJO's sodium excess state be managed? The etiology of LJO's nephrotic syndrome should be identified for specific treatment. Although LJO's serum sodium concentration of 132 milliequivalents per liter is low, it reflects dilution secondary to fluid excess. Salt restriction is therefore important to control LJO's generalized edema. For most nephrotic patients, modest dietary sodium restriction to approximately 50 milliequivalents per day may be sufficient to maintain neutral sodium balance. For nephrotic patients who are very sodium avid, urine sodium concentration below 10 milliequivalents per liter, sufficient restriction is difficult to achieve. Thus, slowing the rate of edema formation rather than hastening its resolution should be the goal of therapy for these patients. Bed rest reduces orthostatic stimulation of the renin-angiotensin-aldosterone and sympathetic systems, thereby favoring the movement of interstitial fluid into the vascular space. The central blood volume is thus increased and natriuresis and diuresis are facilitated. Prolonged bed rest might, however, predispose these hypercoagulable patients to thromboembolism. Similarly, use of support stockings may reduce the stimulation for sodium retention by redistributing blood volume to the central circulation. Next we will discuss diuretics. Usually, loop diuretics are the mainstay of therapy in the management of nephrotic edema in most of these patients. The edema can be removed safely with rapid diuresis without compromising the systemic circulation, probably because of the rapid refilling of the plasma volume by interstitial fluid. Nevertheless, as the edema resolves, the rate of fluid removal and weight loss should be decreased to avoid compromising the effective circulating volume. The patient should be monitored for the development of orthostatic hypotension. Infusions of albumin can expand the plasma volume. However, it is expensive, the relief is temporary, and it should therefore be used only for resistant edema. In patients who are resistant to the aforementioned measures, extracorporeal fluid removal, namely ultrafiltration, may be necessary. LJO was initially treated with IV furosemide 60 mg twice daily and placed on a low sodium, that is 50 milliequivalents, low fat, high complex carbohydrate diet that consisted of 0.8 gram per kilogram protein of high biologic value with additional protein to match gram per gram of urinary protein loss. Fluid was restricted to 1,000 milliliters per day. He had 5 liters of diuresis in 2 days, with resolution of respiratory symptoms and a reduction in the anasarca. Parenteral furosemide was discontinued on the 5th day of hospitalization and oral furosemide 120 mg twice daily was started. After a total weight loss of 12 kg, he was then discharged with instructions to maintain the diet and oral furosemide. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 369.